Okay, we're going to try this one again. It's going to be our discussion over atrial dysrhythmias. I apologize. Apparently, my recording program had zoomed in, and I did not look at it before I posted to YouTube. So I'll take it down and I'll put this new one up. So basically, we have talked about the parts of the QRS complex and how to identify what a normal complex would look like. So we see P, QRS, and T. Right? This particular one has a U wave, but that doesn't mean anything for us, so don't get too excited. What we're going to try to think about is that process where the heart has automaticity, it has excitability, conductivity, contractility. All of those same things are going to, one, help us maintain good cardiac output, but two, also potentially put us at risk for these atrial dysrhythmias, especially if we have a long cardiovascular history. So we've talked about what the P wave is. It represents atrial contraction. Generally speaking, if I'm going to have a dysrhythmia that's going to be considered an atrial dysrhythmia, that is where the main issue will be. You do have some differences, but as far as the rhythms that are testable, we're going to talk about just a SVT, so a supraventricular tachycardia. It's above the ventricles. Tachycardia will give you the ranges that I'm going to use for that. It's also called PSVT, so paroxysmal supraventricular tachycardia, which just means it has the sudden onset. Then we're going to also discuss AFib and aflutter. A lot of the emphasis for us is going to be on AFib, since that is the most common dysrhythmia there. But before we get to those topics, we're going to talk just about those benign beats. So those benign beats are going to usually have a P wave in front of them. We're going to call those premature atrial contractions. So again, we understand that there should be a P in front of every QRS. If there are no P waves, we've got to make kind of a determination about what the rest of the rhythm looks like to be able to identify it. But once you do it a few times, it's pretty straightforward. So, as we are looking, again, we're going to count the atrial rate with the ventricular rate. We want to make sure that we're counting our 6-second strip. Again, that's something that I would give my students. If I gave them this rhythm, I would say in my question, the nurse is reviewing the client's telemetry. This is a 6-second strip. So we do see that we have consistency. So for us, for just basic nursing, what we're going to look at when we're considering if this is going to be an atrial or a ventricular dysrhythmia is the presence of the P wave. Sometimes, though, that P wave can be hard to distinguish. So generally what we're going to do for the rhythms that we're going to talk about, we're going to say that if that QRS complex is skinny, then it's probably in the atria. I don't teach my students about idioventricular or junctional dysrhythmias. They will learn that as they progress in their nursing career, depending on what career specialty they will go into. So try to, if you are familiar with those rhythms, just try to put them on the back burner because they're not testable in nursing school, at least for my nurses. So we also understand that if I have this PQRST and it comes early and I have this compensatory pause, that's going to be an ectopic beat. And remember when we talked about our PACs, so our premature atrial contraction, which is the ectopic beat, we have said that you have to have that kind of compensatory pause. It has to come early. They're extra beats, so that signal is generating from somewhere other than the SA node. And when I say somewhere other than, we're going to be very specific. So if we draw our box for our atriums, so the top part of our atriums, each cell up here has the ability to produce another signal. So if this were the SA node and we had this signal that caused that initial contraction, not too long after that, you're going to have another signal come from another part of the heart, or of the atrium in this particular case, that is going to initiate that extra or that early beat. So typically, my patients don't really say a whole lot. They can say that, oh my gosh, it felt like I had, a skip beat, or I'm having palpitations, but generally speaking, they're going to be asymptomatic. We have these all the time. It's usually electrolyte issues. It's usually volume status issues. We just need to recognize that there's a huge difference from having 1 or 2 PACs from having 18 or 20 PACs. And if you do have 18 or 20, it's no longer an ectopic beat. You're actually in SVT, because that fast atrial tachyarrhythmia is signaling to have your atrias fire at a rapid rate, and your ventricles are going to respond to that atrial contraction. We'll give you examples of that. So a premature atrial contraction, we consider that an ectopic beat. We know that it has to have an underlying rhythm. It can't just be a PAC. If you document that as the rhythm, it will be incorrect. So this particular rhythm, I'll count the atrial and ventricle rate. Because they're easy to identify, I can see that they are the same. But what I do notice is when I compare this R to R, which is roughly 3 3/4 of a box, to this R and R, which is roughly 2.5 boxes, this complex and this complex came earlier than I would have expected. So what I'll do is I'll mark here, this is kind of where I thought the beat should come, and then you have a compensatory pause. And again, what I want to look for is the tall and skinny QRS, and again, it doesn't have to be tall because we don't care about up or down, we care about left or right. That is going to be considered that ectopic beat. Now, this person is having a couple of ectopic beats. They are unifocal in nature, which means they go in the same way. They definitely come early. What we probably need to do is just go assess the client, look at their laboratory values, and figure out if we can treat the underlying cause of whatever is causing that ectopic contraction. So we've said that they're not significant, especially in younger folks who have healthy hearts. They can become more troublesome if you do have that long cardiovascular history. So they can be a warning sign. A lot of treatments, most substantially, is just treat the underlying cause. If they have a low potassium or a high potassium, low magnesium, high magnesium, etc., we're going to do electrolyte replacement. We'll do K runs, we'll do mag runs. If they're not satting enough, we can give supplemental oxygen. If they are dehydrated, any number of causes. If those things do not work, we could consider adding something that would potentially slow down your heart rate. Now, we specifically say beta blockers here because that's probably the most common. It's the one that you folks are all familiar with that will have an effect on heart rate. However, I can also use a calcium channel blocker because that will slow down electricity. So it depends on what the clients are responsive to and what the healthcare provider prefers to accomplish. We talked about stress, fatigue, caffeine, tobacco, smoking, drinking, all the bad stuff, hypoxia, and we're just going to observe them. So we're going to document this. It's a sinus rhythm with, in this particular case, I could say frequent, I could say rare, I could say occasional PACs. And on telemetry, what you see right away is that the PQRS is moving right along, and then basically right underneath the word lead on that right-hand side, we see that early premature ventricular contraction. So if this is on a monitor, you can see that it may be difficult to identify because it does happen fairly quickly. Luckily for us, the machines are pretty good at telling us that you have an irregular R to R, which just means that you need to look at it. So is it an ectopic beat, or are we an AFib, or some other underlying rhythm? So that is a PAC. Now we're going to talk about atrial tachycardia, and we've given that many names: SVT, PSVT. Paroxysmal is just a fancy way of saying it starts suddenly and then stops. So you have paroxysmal supraventricular tachycardia, paroxysmal nocturnal dyspnea. We know, again, that this rhythm is going to originate above the ventricles, so it's in the atria. We are going to use a rate greater than 150, but often in the literature, in the books, you'll see 160 to 250. So again, we may not see signs and symptoms until that client is, 200, 210, 220 beats a minute. Typically, the clients will be observed as feeling kind of tired, kind of feeling like their heart is racing. They have that general malaise feeling, depending on the severity of the tachycardia, because what we do is we lose that filling time. So if we lose filling time, if we lose stroke volume, we lose cardiac output. Again, we should be looking for regular, narrow QRS complexes. Sometimes those P waves can be hidden, and that's why I said we're just going to look at that QRS if we can't kind of figure out, okay, is this really an atrial tachycardia or SVT, or is it something else? Lots of things can cause this: genetics, age, stress, heat, stimulants, medications, other cardiac disease processes. And again, the worst outcome is that they are going to become symptomatic, which could include unresponsive with this really, really fast heart rate. And of course, the longer that we let that heart rate go at those really high numbers, the more and more symptomatic that they're going to become. So they'll experience palpitations, anxiety, hypotension, changes in their breathing pattern. They may present with some sort of chest pain. So we need to ask ourselves, is the patient stable or unstable? Are we going to get a full set of vital signs? Do we have supplemental oxygen available? What is their LOC? If stable, we can absolutely try vagal maneuvers. So vagal or Valsalva. Again, this is not something that I would recommend a nurse doing unless they had a specific order to do so, because if we tell a client to bear down and they vagal all the way down and don't come back, and I didn't have an order, I could get into a lot of trouble. If those things don't work, generally speaking, what we would try is this medication called adenosine. And again, this is one of our A drugs, a frequently missed question on my exams because we confuse all of the A drugs. So we're going to do adenosine is atrial death. And that's exactly what we're looking for. This administration of adenosine, giving literally over like 2 to 5 seconds, is going to slow down conduction. But it's going to slow down conduction so much that they're going to have a period of asystole. Our goal is to restore, and we say a sinus rhythm here, but our goal is really to restore a stable rhythm. The sinus rhythm would just be the most stable. Right? If they are unstable, we could do a cardioversion. So remember, that's the less electricity. We're not defibrillating SVT. We're cardioverting SVT. We cardiovert stable atrial dysrhythmias or stable ventricular dysrhythmias. And again, you want to make sure that we're monitoring this client. There's a lot of things that we talked about, those triggers that we're going to do some patient teaching on. And we may send them home with some long-term medications. Again, a beta blocker will slow down their heart rate, but it may not be enough. We could consider using a calcium channel blocker, so sending them home on a PO medication regimen. You could send them home with PO amiodarone, because amiodarone will slow down the ventricular response. If we still have issues, we can send them down for an electrophysiology ablation. And that's not something that I would test you guys on. It's just that we're going to go and we're going to try to identify the area of the extra stimuli and basically, for lack of a better term, burn it away. So here is SVT in a nutshell. If this were my 6-second strip and I said, hey, this client presents to the ED, they're complaining of chest pain, shortness of breath, you put them on the telemetry monitor and we see this, what is it? Supraventricular tachycardia. Notice, I'll try to make it make sense. It can be hard with this pen, but I'm going to follow the RS and then I come back up to the T. And what happens is, because this rate is so fast, you see how small the R to R interval is? The P wave is there, it's present, it's just buried in this T wave. And I don't know if you can see this little bitty bump, and that's kind of where the machine is probably trying to blend those two waves together. I understand that it's SVT or PSVT because the rate is really fast, the QRSs are really skinny, and that's going to be our criteria. So, when we say a sudden onset of PSVT, what I want us to notice is, first thing, I can look at this, the top, I'm going to look at the top row here. This is a continuous tracing. I see that not everything is exactly like it's supposed to be. I see some non-conducted QRSs. I don't know if this is ectopy or, not ectopy, excuse me. I don't know if this is artifact or if it's actually because we have delays in conduction. For the most part, we're moving along pretty regularly. The red arrows are my 6-second strip. So I can see I have a heart rate of 1, 2, 3, 4, 5, 6, 7, 8, 9. So 90 to 100-ish, 100-ish to 110 if we count this non-conducted QRS. And again, I won't put any non-conducted QRSs on our exam. Then what happens is suddenly, the proximally, I see this change in my heart rate. No, you don't see a whole lot of change in the size of the QRS. Notice what we do see is that it kind of flips the other way. So what we mean when we say that it's flipping up down, we're just describing that QRS complex. You know, the first line, it's pointed towards the ceiling, and then when it flips over, it's pointing to the floor. These are, well, these are any number of issues, but they're kind of like more in-depth issues. So we're talking about aberrant conduction systems. We're talking about re-entry tachycardias. I don't want you folks to get confused if you were to see something like this. It's just basically how the machine is monitoring what is going on in your atria at any specific time. So there's not a whole lot that it doesn't mean something nefarious. It just means instead of viewing it from one direction, we're viewing it now from a different direction. So what I'm going to do is just count out again my QRSs. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. So it is right there at that cusp of what we would consider SVT. So this particular person, because I can keep counting it, 16 plus another 7, so 23 beat run of SVT. So yeah, so the heart rate could get up to 230-ish if we allow it to keep going. Now, your heart, again, is kind of awesome. It knows it's not supposed to be doing that. So what happens here is it sort of self-corrects. And what you will see when you look at your QRS complex, it's kind of back to where we started from. Remember, your heart wants to beat in a rhythmic pattern. So again, for us, we're talking simple things, have them bear down. We're going to give medications, specifically adenosine is the only medication that I would give for SVT. Sorry. Adenosine, SVT is the only rhythm that I would give adenosine for. That sounds much better. So again, we can kind of see how we counted those out. So, couple of helpful hints, right? We know we've talked about the kind of straightforward stuff. So stable SVT, perform vagal maneuvers, Valsalva maneuvers, IV adenosine. Unstable is usually going to be some sort of synchronized cardioversion. Just because this is listed as the option, it does not mean it's the be-all, end-all. It depends. I'm probably done more diltiazem and amiodarone infusions than I've ever seen IV adenosine given. Think about where we're at and what's going on. Are we in the ICU when this happens, or are we out on the floor when this happens? Typically, most of the time, this could be somebody that was sent to a step-down unit. So again, we're going to list out our A, B, C, Ds, and Es. So our amislodorone, again, notice it's that other A drug. Adenosine, beta blockers, calcium channel blockers. Usually for rhythms, it's going to be diltiazem and verapamil. And again, I don't test over verapamil. Cardioversion, we talked about the synchronized cardioversion. You can use digoxin. Digoxin will have an effect on the electricity of your heart. Or we can do the radiofrequency catheter ablation. They're using that as their excitation piece, where we're going and burning out that area that's causing the dysrhythmia. And here's kind of what it looks like. Now, on this particular one, you do see that the T wave at least attempts to come back down to that isometric line. But then we do see that we have this P wave, probably a very large P wave. So I don't know, maybe they have some sort of atrial enlargement or something as well. So we think about our acute situations, the first line treatments, but it's really the least invasive thing we can do, even though I'm trying to get them to lower their heart rate. Unfortunately, it's not always effective, especially if they have recurring issues of going into SVT. The monitoring is exactly the same for any other dysrhythmia, continuous telemetry monitoring. And then as we're administering medications, especially if they're on a continuous infusion of either diltiazem or amiodarone, making sure that you're doing frequent vital signs because they can both lower your blood pressure. For adenosine, it is acute treatment for terminating SVT. By terminating, I mean we send you into asystole for a brief period of time. clients can experience flushing, they can experience chest pain, and we talked about the brief asystole. And the monitoring is exactly the same. Radiofrequency catheter ablation, right, is for treatment of recurrent or drug-resistant SVT. We're going to insert a catheter, and it's going to help deliver this radiofrequency energy. That it's either a sound or laser, usually, which is going to destroy that small area that is sending out that aberrant signal. It's very invasive, obviously. That's the con. And with any of those procedures that are done in the cath lab, we know that bleeding and infection or damage are going to be a risk. If I'm trying to get in there and do this radiofrequency catheter ablation, I could literally send you into a lethal dysrhythmia because of the manipulation of that catheter. Monitoring, exactly the same. Cardioversion, we're going to say cardioversion, again, is going to be one of those things that I can do. It's going to be with less electricity. I'm going to do it particularly if the client is symptomatic or is close to being hemodynamically unstable. We're going to just make sure that because I'm still shocking them, that I am giving them medication. And again, usually it's going to be some sort of fentanyl and midazolam combination. It would hurt. So we want to make sure that we are protecting them with those medications. And then we also want to make sure that we are protecting the client's airway. So generally monitoring is pretty much the same, and the outcome is the same because I want them to go back into a stable rhythm. So that's it for SVT. If you can identify SVT by the rate, and if you can remember adenosine, diltiazem, and cardioversion, you're probably doing okay. A-flutter. So A-flutter and AFib. What I have going on in the atria are just this total disorganized kind of chaos. We can call these, we don't call them P waves anymore. We're going to call them F waves, fib and flutter. Usually what you're going to see with atrial flutter is a sawtooth pattern. You're going to see skinny QRSs, and you're going to see generally, I will give you the exception to this, a generally consistent R to R interval. I'm not too worried about A-flutter. I don't see A-flutter a whole lot. The clients that I do are typically clients who are going in and out of AFib A-flutter. But because the atrias are still firing at a really fast rate, I'm still going to give medications to slow down that electricity. I don't need to slow down the ventricular response in this particular instance because my heart rate is 70 to 80-ish in the ventricles. In the atria, it's going to be in the 200s to 300s kind of range. Long term, again, we're going to lose that atrial kick. It's not going to affect cardiac output a whole lot until I get a flutter with a rapid ventricular response. We're going to talk about AFib with RVR more than we will with a flutter. And because of this, all of these atrial dysrhythmias increase our client's risk for stroke, MI, clots, all the bad stuff that we don't want to happen. For this particular client, I may choose to either chemically cardiovert them or electrically cardiovert them. So, chemical cardioversion, again, we can think about digoxin, we could think about calcium channel blockers, the diltiazem, the beta blockers to slow down the ventricle rate if it's too fast. Again, just be careful. Make sure you're doing your pre-assessments for your beta blockers. Make sure you're monitoring the blood pressures if you've got them on a continuous infusion of a calcium channel blocker. And again, we may choose to electrically cardiovert them as well. So the first thing that I notice with this one is everything I said is mostly true. Some people will go, oh, well, that doesn't look like a saw to me. And I get it, right? But it's the best interpretation that I have because your R to R is consistent and there are no discernible P waves. And you can say, oh, well, isn't that the P wave? And I'm going to say, no, that's an F wave. I don't know 100% if that is a P wave. This client has set up, well, this client and the last client have set up what's called a therapeutic block. That's something that we expect with a flutter that you don't see in AFib. That therapeutic block is the reason my R to R's can stay consistent. And then I have a 1, 2, 3, 4 to 1. So each of those little shark fins is a therapeutic block. This just happens to be a 4 to 1. So 4 F waves for every 1 QRS. It's great if it does that, but sometimes you have A flutters that are having a 3 to 1 block and then a 2 to 1 block and then a 4 to 1 block, and it's going to look a lot like AFib. That's why we get a 12 lead. Fibrillation, atrial fibrillation, we've said is the most common dysrhythmia there is, right? I don't get overly concerned about clients until that heart rate probably gets to the 130s, 140s, 150s, right? That's going to be called AFib with RVR, again, rapid ventricular rate or response. If they don't have an RVR, I'm even less concerned about them. And generally, if they're non-responsive to therapies, I can send folks home in AFib and A-flutter as long as they're taking medications. Medications are usually going to be some sort of antidysrhythmic and an antiplatelet and an thrombolytic, not a thrombolytic, excuse me, an anticoagulant. If I count this client's heart rate, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So their heart rate is somewhere around 100 to 110. That would technically be AFib with RVR. I'm probably not doing anything with this. If we've already started therapy, that's great. But I'm not worried. Would I still go assess my client if this were new, acute? Absolutely. But generally speaking, this rhythm will still be able to maintain perfusion because of the ventricles and in spite of the atria. So we kind of see in the illustration up in the upper right the disorganization of the electrical signal and where it's kind of generating from other places. The little black dot in the upper left-hand corner of the heart is the SA node. And then you can see the other white dots are the disorganized electricity. Our goal is to decrease the heart rate, to prevent stroke, to use medications to control the rate, and convert them, if possible, to a stable rhythm. We do expect them to be on long-term anticoagulation therapy. Again, warfarin is still a big one for us. We do see more and more next-gen direct oral anticoagulants. So we're thinking of the dabigatran and the rivaroxaban. That one 3 times fast. And of course, there's apixaban, Eliquis. I would say that as of right now, what I'm getting is that these are probably the most common ones that people would run into. Not all AFib is equal. We know that. Because of that long-term anticoagulation therapy, bleeding can become more significant, especially if we use warfarin with NSAIDs, anticonvulsants, herbal supplements, antidepressants, so your SSRIs, and of course your other medications like amiodarone or heparin. But of course we can still, and we do expect if you're on heparin initially, that we're going to put you on heparin and warfarin just until your INR becomes therapeutic. We should all be familiar with warfarin monitoring. Remember, it's 1, and then it's 2 to 3 times 1 to be therapeutic, so that's our target range. Again, the biggest complication, especially if they've come in and we put them on a heparin continuous infusion, is going to be bleeding. And once we send them home, we're going to send them home with a PO, and the biggest issue will be compliance. So our direct oral anticoagulants, I will tell you again that it's getting more and more common, and I am being told that these have finally made their way towards NCLEX RN. These don't require those same therapeutic level monitoring that warfarin would, but we do know that we now have antidotes for those next gens, and again, this is why you are seeing more and more use of these, because now we have safety measures in place. So kind of outlined it here for you. I wouldn't expect too many questions over these. I don't expect that you would get these questions a lot on NCLEX. It just kind of depends. But I do want you to figure out that, we're looking at the AN. All right, so if we're thinking about how am I going to remember these, notice that they all end in AN. And for the most part, the side effects are fairly consistent, and I would imagine that since bleeding and bruising are the most common, that's probably what you would look at. We want to make sure that we're preventing strokes. You see that that's the same in all three. You do have some drug alerts. Again, that's not really, to me, a decision that a nurse is going to make. The apixaban is the easiest one because it's just contraindicated with active bleeding, but they would all be contraindicated in active bleeding. And then the nursing considerations, you see that those are pretty much the same. So we've already identified AFib and AFib with RVR. We can still do chemical or electrical cardioversion. Again, chemical is probably going to be your amislodorone or your diltiazem. You can still cardiovert this client. And the books do say, despite what some literature says, that if the client has been in AFib for greater than 48 hours, and again, that's not something that we're going to probably know, that they need to be anticoagulated before we perform cardioversion for X amount of weeks. So here we see 3 to 4, and then following cardioversion for 4 to 6. Now, this is another one of those, but it depends. It depends on what your doctor wants to do. If I am concerned about a blood clot, I could certainly ask for a echo to see if there are any clots in the atria that I would risk putting out into circulation if I did cardiovert you. So here is AFib with RVR. You do see that we have our markers for our 6-second strip. So we'll just go along between these. So I'm not going to count this first one. We'll give it a little credit at the end. But I see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. So now that heart rate is like 180-ish, 180 plus. That is not going to be something that could be sustained for a long period of time. Your ventricles are going really well, but because of the increased rate, they're going to lose the majority of the atrial kick, and they're going to lose filling time, which is going to severely affect their stroke volume. So if we're thinking of this and we can say, okay, my heart rate is 180, but my stroke volume is only 10 milliliters, my cardiac output is only 1.8. And that is not going to be enough. Worst case scenario, 10 milliliters, but I mean, even if you wanted to take it up to 20 milliliters at a heart rate of 180, it's still going to be less than our 4 to 6 liters per minute. And here's just a normal AFib on telemetry. What I notice here, and this is what I point out to all my students, is see how that heart rate is just jumping around. Your monitors are going to have issues with the heart rate going up, down. They're going to have issues with your R to R. And again, if it's new, make sure you grab a 12 lead, and then we're going to make sure that we notify the healthcare provider that they've gone into a new dysrhythmia. So we have said chemical cardioversion, and I wanted to give you guys kind of a little breakdown again of what we would expect. So we've talked about adenosine and the fact that we're only going to use that for SVT. We've talked the use of beta blockers. It says metoprolol, but it could be labetalol, atenolol, whatever it may be. And again, diltiazem, digoxin, and amiodarone. I included the ACLS drugs down there just because, but notice they're in purple, so they're not testable. So, here's our trick question. What is this? The first thing that I notice is that my QRSs are skinny, but then I definitely notice that there is some inconsistencies in my R to R. Now what I do see is that I have the QRS, and then it comes back to the isometric line, and then I have this T wave. Okay, that's totally fine. I can see that. I can say that that's a T wave. It has nothing to do with the P wave. So there are no identifiable P waves. There's not even really an identifiable F wave. You could call these little bumps F waves. But I know because of the irregularity that this is an atrial dysrhythmia, and it is indeed AFib with RVR. So, just looking from a, hey, this is on the exam, we noticed right away, if I put this on the exam and it said, how should the nurse document this rhythm, that it is an underlying rhythm because I only have one ectopic beat. One thing came early, it's skinny. I would call this a sinus rhythm with PAC. Again, I'm not doing a whole lot. I'm not running down the hall, but I will go and check their MAR, check their electrolytes. I can check their SpO2 and make sure that we're not having runs of PACs. Okay, these two rhythms are exactly the same. And again, this is why I put them on here, because I wanted to outline, oh my gosh, those are pretty F waves up top, right? I see a 4-to-1 block. Down here, I see more of a 1, 2, 3, 4, 5, 6-to-1 block. 6-to-1 block, but it doesn't really do anything because I can see that my R to Rs, for the most part, are fairly consistent. I think it's more consistent between the second and last little segment here. And again, I put these on here. They are the exact same rhythm. This first one is very noticeable as AFib. It's right on that cusp of being tachy. the reason I put the second one here is that it's a little harder to notice. But what I do notice is that there is no identifiable P wave, and then I also have this T wave inversion. So then that's going to make me look a little closer. I see that this R to R is about 3 3/4, whereas this R to R is only like 3 1/4. And then this one is 4 1/4. And then I have this one, which is about the same-ish. Then I go right back to a 3 1/4 R to R. It's still AFib. And that is it. That's all you need to know for your atrial dysrhythmias. Again, I would focus on the things that are different because the nursing care is pretty much the same with the exception of adenosine, and be able to easily identify AFib and A flutter, and then make sure you're counting the rate for SVT.